Hello. Welcome. We are about to start. I just wanted to give you a quick introduction to how this is going to work. You are all connected in listen-only mode. So if you have any questions during the presentation, please enter them into the chat box. We will answer all questions at the end of the presentation so that we have plenty of time for the presenters to get through their material, but we have plenty of time also at the end for discussion. And we hope that we have lots of great discussion. And also this webinar is being recorded, and we will make the recording available at the end of the presentation and post it on our website too. So for those of you that don't know me, my name is Corey Miles. I am a senior environmental planner at the Northern Virginia Regional Commission. And for those of you that aren't familiar with the commission, it is a sub-state agency that works to help coordinate and facilitate cooperation among the local jurisdictions of Northern Virginia on issues of regional concern. And one of our program areas includes regional trails, more specifically the Potomac Heritage National Scenic Trail, with support from the National Park Service. We are happy to be working with the National Park Service as well as the Virginia Department of Health on this project, on this webinar, and also a healthcare provider with ParkRx America, who actually prescribes trails and parks as part of their practice. So to start off, we are going to hear from Ann O'Neill, who is an outdoor recreation planner with the National Park Service in the Capital Region. And I am going to start sharing her screen. Bear with me just a moment. Here we go. Ann, I have made you the presenter. I'm going to hide myself.
Okay. Hi, everyone.
Go ahead.
Good afternoon. Okay, thanks, Corey. Good afternoon, everyone. I'm excited to be with you this afternoon, and I just wanted to take a moment. Today is a really special day. August 25th is actually the birthday of the National Park Service. So today the National Park Service is 104 years old. So hopefully you can celebrate virtually where you are. It's exciting. So today I'm going to talk a little bit about the National Park Service and different programs and their involvement in terms of find your park, find your trail, and find your health. And just to go over a couple of outcomes from my slides, I'm going to try to give you a grounding in health and outdoor recreation in the National Park Service. So looking at really briefly and quick the history and mission, and maybe some things you have heard of or haven't heard of in terms of healthy parks, healthy people, park prescriptions, and the growing movement to advance outdoor recreation. So some things to celebrate that maybe you've heard about, of course, with the recent signing of the Great American Outdoors Act. So just want to take a look at going back in time, since today is the National Park Service's birthday. An important individual when you think about founding park founders was Frederick Law Olmsted Sr. and his son. And during the Civil War, he actually had a health role before he experienced health provider burnout. And after that, he went out into nature, and shortly after that, he wrote the Yosemite Report. So he spent time out in the Yosemite area And what is striking is, as you probably may or may not know, is that he really connected scenery and nature in terms of benefiting people's emotions and more so mental health. You know, improving physical health is a no-brainer. And so I just wanted to sort of ground ourselves with that. Since early park founders knew this, that wealthy individuals were able to access parks and the common folk needed to have time to be able to access places near them if they didn't have the time or the money to visit places far away. And here's just a little bit of an excerpt from the Organic Act, which created the National Park Service. And I underlined two words that are important: enjoyment and the enjoyment for future generations. And I want you to remember that, because that really is connected with our conversation today. Around this same time, the National Park Service has had a relationship with the Health and Human Services Division. A lot of the work that has been done collaboratively has more been in combating health outbreaks in national parks, but we do have one position that supports health promotion. Diana Allen is our chief of the Healthy Parks, Healthy People initiative. And within the webinar, there are new resources at the link below that hopefully can help you in terms of Healthy Parks, Healthy People, where really we are owning that parks, that places, and the different things that people can do in parks are part of their improving one's health. And so Healthy Parks, Healthy People is like a large umbrella. And then underneath that is park prescriptions, which many of you may have heard about, where actually health providers are beginning to prescribe time in parks and trails for health benefits. And I think when we think about COVID right now, I think a lot about communities that may not have walking or biking access to where they live and how they are coping with COVID. Certainly during this time, we're seeing an increase in use in our parks. I'm sure you all are seeing that, and hopefully you're using parks near you to deal with these uncertain times. And I just want to say that we did kick off park prescriptions in 2016 with the first National Park Prescription Day. And the top right corner, you see the past Surgeon General. And then in the bottom right-hand corner is one of my friends and colleagues, Dr. Robert Czar, who is actually the founder of DC Park Prescriptions, which in 2017 became one of the promising practices within park prescriptions, which is called ParkRx America. And I don't want to go into all of it, but I did provide assistance to the DC Park Prescriptions Coalition to do a lot of mapping, working with many of you to allow for doctors to prescribe our parks in our region to patients and residents for their health. And I think you'll hear a little bit more about that from Sheila. And as you're going to hear more about, most of the parks in our area are free. So most of the national parks do not have an entrance fee. And so that's a good thing if the cost of entering a park might be cost prohibitive. I think one of the challenges, as you know, is some of the parks are not accessible for communities that may not have a car, or if there are no connections with alternative transportation in terms of buses, or if there's no bike share with a place to park it to then go hiking or to have a picnic. When I showed you all the mission of the National Park Service, and I underlined those words enjoyment is really connected with outdoor recreation, and how outdoor recreation is often the hook for people to connect with our parks. And in our area, most visitors don't really see a difference between the local, regional, state, or federal lands. They're just sort of going out to have a good time, to have enjoyment with their friends and family. And one thing I want you to think about when you're thinking about the resources in our area is realizing passive recreation and active recreation have their benefits. And I think oftentimes non-traditional audiences feel intimidated about more expert like outdoor recreation that's very active, like rock climbing or kayaking, whereas most people don't need equipment and are able to go walking if they've got a good pair of shoes and they can find a place that might be flat to start out with. But some of the different passive recreation activities are also helpful in terms of de-stressing and calming oneself. Many of you may have heard that the past secretary issued Executive Orders 3356 and 3366, which are related to outdoor recreation in terms of enhancing and expanding outdoor recreation, as well as providing for opportunities for people to go fishing and, where appropriate, to also go hunting. So something for you to think about. We hear a lot from our communities in Northern Virginia where people are wanting water access. Also, you all may have heard that recently the president signed the Great American Outdoors Act, and we'll hear how that's going to be implemented. Also providing support to the Land and Conservation Fund, which, as you probably know, helps create many local, regional, and state parks, which is pretty exciting. And I think that in our area, as I said before, that recreation is a hook for everyone. And so I think, especially with what's happening in our country right now, thinking about how our parks were created and how we can provide access for everyone, especially those who might be the most vulnerable health-wise, where just providing trail access or connections with bus or bike can improve health. Thinking about future strategies, one of my other roles has been supporting the Potomac Heritage National Scenic Trail. And I just want you all to think about that the trail is a trail corridor where the majority of the trail actually exists on non-National Park Service lands, although it is a congressionally created national park unit. And so it is about collaborating with local, regional, state, and other federal lands to create different types of trail opportunities and to also provide for outdoor recreation experiences for those communities or for visitors that can enhance tourism in the various cities and counties in our area. And with that, I'm going to pass it back to Corey. Oops, I'm sorry, Corey.
Great, thank you, Anne. Let me grab the screen from you. Okay, so let me introduce our next panelist, Sheila Aubois. Hang on, Sheila, let me get you unmuted here. Okay, And now I'm going to, bear with me, I'm facilitating and running the behind the scenes here. So I have to make Sheila the presenter now. And I am going to do that. Okay. So Sheila is one of the providers for ParkRx America. She is a native Northern Virginian practicing medicine as a physician's assistant in an outpatient cardiology office where she focuses on disease prevention and reversal. She also gives health seminars for Inova Health System, local corporations, and Prince William County employees. Sheila is adjunct faculty at the local satellite campus of Shenandoah University's PA program and is actively involved in local, state, regional, and national health advocacy, including ParkRx America. And Sheila, do you have the ability to grab the screen? Okay, I don't know where Sheila went, and all of a sudden she is offline. So we can perhaps move on to Millicent's presentation. So bear with us. Millicent, I'm going to pass the screen over to you. Oh, there's Sheila. Now I see Sheila. Can you, Sheila, do you have, I'm just going to change the presenter to you. Are you ready? Can you hear us?
I can hear you now.
Great. All right, we hear you.
Can you hear me?
Yes, we hear you.
And can you see my blue screen?
I see you. There we go. Now I see your screen.
Okay,
Perfect.
sorry, I had a technical difficulty here where the Wi-Fi just cut out and I had to go on to my hotspot. So hopefully this works now.
Oh, okay, great. I'm glad.
All right.
I'm glad you got it worked out. That's always kind of stressful when something like that happens. All right, I'm gonna let you take it away.
Okay, so I'm here to talk about no, I'm trying to minimize. Can you guys still see the blue screen here? Here we go. So I'm here to talk about ParkRx America. My name is Sheila Aubois, and I am the physician assistant champion, really, of ParkRx America. I contacted Robert Czar and was really excited about this program and have been promoting it to PAs across the country who are now joining up as prescribers. So I have volunteered to for ParkRx America and thought this would be a great conference to join because I live in Northern Virginia and work outside of Richmond in Chester, Virginia. So I prescribe parks in both areas. And so with that, let me see, Corey, do I just put the side arrow to go to the next slide? We're going to try that.
However you.
Yes, okay.
Yes, there you go.
All right, so today we're going to talk about just a few minutes about chronic health issues in all ages of people, the impact of parks and nature on those chronic health conditions, park prescriptions, and collaboration opportunities with ParkRx America. I guess just a second about my background. I actually became a PA later in life. Before that, I was a certified health education specialist, and I worked with Inova Health System. If you all know the major health system in Northern Virginia as a health educator. I also work with Shenandoah University in training some of their students and do a lot of health seminars in various corporations around Northern Virginia. So I have a lot of different contacts and have had the ability to prescribe ParkRx in a lot of different settings. My practice now is in cardiology outside of Richmond, and I'm down here 2 days a week and prescribing ParkRx in nature. So just to get started here, we want to start with the younger age group. Children are unfortunately more sedentary these days. Sadly, the average time a child spends outdoors in free play is 4 to 7 minutes a day. And that's pretty pathetic. The average time they spend in front of a screen has been 6+ hours a day. I believe if we measure that in after the next year, we're going to see that that increases because of the pandemic, right? More children are spending time in front of a screen for school, and we need that, but it's unfortunate it's going to increase their screen time, and if they're in front of a screen, they're not outside. This is a typical picture of what's happening to kids in America. Our health is declining. Pretty much 1 out of every 2 children are overweight or obese, and 80% of children who are obese stay obese for the rest of their life. So it's very important to prevent this from happening, because once it happens, there's not much chance of reversal. We think that 1 out of every 3 children born in the year 2000 is going to develop type 2 diabetes. So these are our 20-year-old kids right now. About a third of them are going to be type 2 diabetics in the next couple of decades. About 1 out of every 4 of our children are diagnosed with a mental health disorder. 20% of children report bullying or worrying a lot. And about 1 out of every 10 children have been diagnosed with attention deficit disorder with hyperactivity. One of the things that I will know about going through my medical education is I spent a whole day at a children's mental health clinic, like a free clinic in Winchester, Virginia. And there was an 8-year-old boy who had a plan and had attempted to commit suicide. I will never forget that I almost cried in the room. And just thinking about an 8-year-old having those thoughts and a plan to take care of it. So we definitely see a lot more stress, a lot more anxiety, a lot more depression in the younger kids these days. And those health issues that children have don't just go away, they persist into adulthood, or we can develop problems as adults. We have 10 million adults in our country suffering from serious mental illness, and these are those who've been diagnosed. There's also an additional amount who have never gone and gotten medical care or gotten a diagnosis. We have almost 30 million Americans now living with type 2 diabetes, which is a lifestyle disease. 70 million adults living with high blood pressure. That number is probably also going to go up, especially with the pandemic right now. We have an influx of patients with high blood pressure and palpitations. We have 90 million Americans that are obese, and 60% of women and 75% of men in our country are either overweight or obese. So that's 2/3 about of women and 3/4 of men overweight or obese in our country. Here's the top 10 causes of death. Most people have seen this list, but I put it up here to show you that almost everything on this list is greatly impacted by lifestyle. And then what I want to get into is the health benefits of spending time in nature. So you all know a lot of these. We've done some studies. We did a study of 5th grade girls and determined that there was a direct link between decreased anxiety, increased resilience, improved sense of well-being, and decreased death and illness in these girls that were living near green space. It didn't even have to be a park. It just needed to be like a wooded area or something even unofficial. But not everyone lives even within walking distance of a green space, sadly. We know that time spent outdoors is associated with improved physical activity, so therefore improved body mass index, weight, less anxiety, less depression. There's something called forest bathing, which was made popular in Asian countries. You just go out into the forest and you can stand there and take it in like you're taking a bath, but you're with the trees. That actually lowers the stress hormone, cortisol, and it lowers blood pressure. And increased cortisol causes or can lead to increased weight gain. So there's a link there with weight as well. We know that living in an area with more opportunity for exercise and physical activity is associated directly with a lower risk of type 2 diabetes as well. here is the nature pyramid. And I put this in to show that, you know, people, when we talk about, oh, I'm going to go have a nature adventure, we might think that it's someplace famous. It's an international destination. These are rare things that people do, maybe once a year, maybe every other year, maybe every 5 years. A national destination people might do more often, maybe once a month. You might go to a national park or something like that. Regional parks, people are tending to go to those even more often, more like a weekly basis. And then our neighborhood parks are really where the focus is, because people are going there locally on a daily basis. So as you get down in the pyramid, you increase the frequency, duration, and intensity of immersion into the nature nearby. We've done more research studies. You know, more and more people are interested in nature. Unfortunately, we don't have enough research studies, but there really is no impetus for funding these studies because there's no drug at the end of the study. You know, the solution is increased time in nature. So there's no pharmaceutical company that wants to fund these types of studies, but nevertheless, a lot of institutions and government funding supports some of these studies where we found a direct relationship between fun programs, free programs, local programs, and weight loss programs, that those increased interest in nature and parks. While on the other hand, lack of time and lack of transportation are barriers to people accessing nature or parks. So those were the reasons people gave as far as less interest in going to nature or park. We have also found that writing a park prescription or providing education about nature has led to increased time outdoors, and it's increasing people's physical activity and decreasing stress. Personally, I know that about 25%, maybe 30% of my patients will actually push a button and say that they filled their prescription if I write a virtual prescription for them. And so I know they're getting out into the park, and I can see a direct impact and know how often they're filling their prescription, just like a pill. But they're definitely more likely to go if I write a prescription than if I just suggest with my words, it would be great if you would go visit a park once a week. They were definitely more willing to go with a prescription. We also know that 13% of park prescriptions or passes to a state park were filled when they were prescribed and counseled by a pediatric provider. Dr. Czar, who founded ParkRx America, and the associate medical director of it are both pediatricians, and have found that not only does it increase the child going to nature when you give the child a park prescription, but it also increases time spent with a family member, because it's not usually the child going to the park space alone, but they're bringing along a parent or an aunt, a relative, somebody else is coming along to the park with them. I included a slide on social justice because that is very important to talk about, and it's right in with everything that we're trying to have conversations about these days. I make no representation that this is at all what happens in Northern Virginia or anywhere else in Virginia, but on a national level, there are definitely disparities with the public green space, the vegetation, and the amount of trees on streets based on your zip code and your neighborhood. So we tend to find that in lower socioeconomic or non-white neighborhoods, there are fewer parks and fewer public green spaces, or less quality parks. So maybe there's no lighting in the park, or there's increased crime, there's less upkeep or less amenities. And we know that greenness is associated with suburbs, with income, with education, and with home ownership. A lot of times when a community builder comes in and builds new houses, they are required to put a green space in. And that may not be the case with some downtown, low-income housing apartments and things like that. The other important thing to know is that with green space comes health benefits, even environmental benefits. So something you may not think about is the ability of people to go outside and take a little stroll, a walk, stand outside. If you have a lot of trees, it is going to lower the temperature for people to be outside. If there are no trees around, there actually is an increase in heat-related illness. There's increased obesity, a link with increased heart disease, and decreased mental health. So the reverse is true too. The more trees you have, the less heat-related illness, the better the mental health, the less heart disease. So getting into our actual platform, ParkRx America is a scalable park prescription model. This is sort of what it looks like when you do a broad search. You can narrow it in to a pinpoint an area around where the patient lives. So we put in the patient's zip code, and we can filter results by what they want to do at the park. So if they say, I want to go to the park to bicycle, you can select their zip code and you can look for parks specifically with bike trails, for example. Or if they want to go for a picnic, you can look for a park specifically with picnic tables. It's all based on the park information that's loaded into the database. Or my patient might say, I live in a very rural area, I don't find any parks in their zip code. I can enter a custom destination. Maybe they know about a green space down the road from them, and they say, that's where I'm going to go for my nature. I can enter a custom destination and say that green space at the end of your street, you're going to go 3 days a week, take a picnic lunch, go for a walk, whatever it is. We work together on making a prescription for them, something that's going to be doable. So we have resources on ParkRx America for both the health professionals side and for the park agencies side. For the health professionals, we actually register as a prescriber, and then we have access to the database to prescribe the parks. For the park agencies have access to loading park information directly live into the database and for controlling that information. So let's say you used to have picnic tables at a particular park, but then they got taken away. You can easily go in and update the listing so that that's a live updated thing. And we have people on staff who help with the technology, the back end, and the parks loaded into the database. Our goal is to make parks and green spaces available in all communities across the country. That would be ideal. So what does a nature prescription look like? First, like I said, we identify parks that may be close to the patient or close to where they work, in an area they might want to go. As you can see on the bottom left, you can check off by amenities or type of trail or type of activity. And then the park prescription actually looks to me what the middle part of the screen looks like. I'm actually prescribing. I write it like a prescription. Take a workout at the fitness stations every Monday and Saturday for 60 minutes. And there's a specific park listed here, Langdon Park. I type in the patient's mobile phone number, hit send by text, send it to the patient. I can set up a reminder if that's what they want. And this reminder is going to come every 3 days for a month. And every time they get the reminder, they can click on a button that says, I filled this prescription, and then I get notified of that. And so does ParkRx, and we keep track of how many prescriptions are filled. As far as documentation, there's an easy way that I can copy and paste their specific prescription into my electronic medical record. So it's in their chart, and I can see the exact prescription. So next time I see the patient, I can follow up and ask them, how was your park prescription? How's that going with your prescription? And my patients get a real hoot out of being prescribed a park instead of a pill. So statistics, we have 925 prescribers registered across the 50 states. We've written over 3,000 prescriptions, and about 25% of them are marked as filled. We believe that more of them are being filled just based on conversations we have with our patients when they come back, but sometimes they didn't carry their cell phone with them, or they forgot to go back in and mark that it was filled. But a lot more of them are filling the prescription than are marking it as filled. As far as on the park side, we have 9,763 parks in the database across all 50 states, and over 1,200 unique parks have been specifically prescribed by our prescribers. So that's a lot of different parks that patients have visited based on us prescribing a park to a patient. And again, I would say the majority of my park prescriptions are at custom destinations. So I find this statistic very good, that we've also prescribed 1,242 unique parks. And then sort of wrapping it up here, I've got some ideas for ways to work together between healthcare providers and the parks. We have posters that are free on our website. I just downloaded, I helped develop the two on either side actually, because I know that patients sit in the room waiting for the provider and are looking around the room. So I have these little posters on the wall. Are you suffering from low energy, depression, diabetes, lack of connection, sleep problems, stress, high blood pressure, weight issues? Time in nature can improve these symptoms. Ask your provider for a nature prescription. So this prompts the patient to have a conversation with me and say, you know, it's nature prescription, and we can start a discussion about that. It just takes a couple of minutes out of the visit to actually have that discussion and prescribe a PARK. The one on the right is for children, so that would be in a pediatrician's office, and the poster in the middle is actually a full-size poster downloadable from our website that talks about the benefits of PARKs. So we can put these posters up in different healthcare provider offices. We could work with county agencies to put them in WIC offices or other places where the public would come and see them, and it could inspire conversations with people's individual healthcare providers. Posters can be put up at parks about the benefits of parks. Many people don't think about the health benefits. They're just there for a program or to see nature, but they're not thinking about the actual health benefits of the nature. We can work with parks to give talks or walk with a doc type thing. There's an actual program called Walk with a Doc where physicians and other healthcare providers can come out and just have an overall health conversation with a group of people who are taking a walk through a park. There's naturalists as well, certified nature forest therapy guides, and those type of guides can walk through the park as well and teach groups of people how to do different things in nature, enjoy nature, meditate in nature, do forest bathing, all those types of things. And then we can work together to improve park amenities, the quality of amenities and the quantity of amenities. That is the goal, to have a park that people can go to no matter where they live across the 50 states, and increase the knowledge about those parks for people. I think that is my last slide. I have the website here for ParkRxAmerica.org, and if you go to the contact section or type this out with the /contact, you get to the page where there's a phone number, an email address, and a web form. So you could type in there, ask for more information. If you want to get connected through ParkRx America and find ways to list your parks, this is the best place to start. And I will turn it back to Corey.
Okay, thank you, Sheila. I think I am probably not alone in thinking that those statistics that you shared are staggering. I almost don't even know how to describe it. It is like, it's very, very sad.
I think sad is a good word. It's very sad.
Yeah, and the effects from the current pandemic is only going to make things worse, as children are basically sitting at home all day in front of a computer. Wow. Okay. Well, I'm going to turn it over to Millicent now. So thank you very much, Sheila. We're going to have some discussion once Millicent finishes her presentation. So let me change the presenters here. All right, we see your screen now. I'm going to turn Sheila's webcam off. Hang on just a second here. Okay, and Millicent, can you unmute yourself?
Yes, I can.
Oh, okay, now we can hear you.
Okay,
We
perfect.
can't see you though. Do you want to be seen?
Yeah, I've turned my webcam off because it does some weird things trying to share my screen and my webcam.
Okay,
so
no problem.
I'll keep it off for now. Maybe during the Q&A portion, I'll bring myself back on.
Okay, all right. Let me just give you a quick intro and then you can take over. Okay, so Millicent Miller is a health improvement supervisor with Virginia Department of Health. She has a Master's of Science in Public Health from University of North Carolina, and she's working to complete her doctorate in public health from Georgia Southern University. She's got over a decade of experience in public and nonprofit sectors, doing program development and management, grant writing, health communication, and evaluation. She's currently the health improvement supervisor at the Virginia Department of Health, where she works to reduce chronic disease burden across the lifespan in all sectors to ensure that Virginians have the opportunity to learn and become healthy, thriving, and resilient adults. Ultimately, she is hoping that her work provides opportunities to build multi-sectoral partnerships in an effort to reduce health inequities and health disparities. And I'm going to mute myself, and you can take it away, Millicent.
Thank you so much for that introduction. And thank you also to the two previous speakers. I think there's a lot of synergy, and I'll try not to repeat the great things that you've already stated. So my presentation is a little bit different in that I'm going to be looking at the data aspects, but I think that we'll all see that there are similarities in terms of how we're able to use data to inform decisions and then also promote opportunities for health and wellness so that we in turn can promote better health for all Virginians. So the overarching learning objectives, I'll just hit the highlights here. So I'm going to do a basic Public Health 101. I know that there are some folks from either the central office for VDH and then also maybe some local health districts, but just to provide a basic level of understanding to level set. And then I'll touch on the common uses of public health data, how to understand and use these data in public health settings, but more importantly, how to collaborate across sectors and the utilization of these data, and then also how you can access and apply data to your own sector to improve outcomes. And those outcomes can be health related, economic related, environmental related. A variety of different outcomes can come from the use of these data. So first, again, going back to the level setting and what is health? You know, that is a simple word, yet when you try to think of a definition, it can be a little bit challenging to put it into words because it's something that we all take for granted until we're not healthy or we're not well. And so health is a state of complete physical, social, and mental well-being, and not merely the absence of disease or infirmity. So typically we think of someone being healthy, they're being well, they're fit, they're eating the right things, they're getting physical activity, and all of the right things that we need to do in order to maintain optimal health. But health strictly is just that state, whether it's good or bad. You know, we know folks who are very healthy or have positive health and those who aren't, who have more negative health outcomes. And so health is dependent upon a complex system or set of systems that intersect and influence one another. And then taking it a step further to think about what public health is. So what is public health, and even more so, why is it important? So public health is the science of protecting and improving the health of people and their communities. So again, it's not just based on an individual, but it's also based on communities or populations. And so this work is achieved by promoting healthy lifestyles, researching disease and injury prevention, detecting and preventing and responding to infectious diseases as well. So public health is a very wide discipline. And I think a lot of people don't really realize how much public health touches. And I always say, you know, if you give me a topic, I can relate it to public health. I think that us who consider ourselves public health practitioners find a way to connect everything back to public health. And so as you can see here on the screen, there are a variety of different areas that public health touches. And by all means, this is not an exhaustive list of all that public health does. But I think we've been in the news more so as it relates to COVID-19 response efforts and all the great work that's going on at the local and state and national level to ensure that we're all safe. But it's not just restaurant inspections, as a lot of people think that we do, or checking pools or giving vaccines. So our work touches a lot of different areas, from motor vehicle safety to safe and healthier foods, family planning, looking at policy and regulation, especially around hazardous or health hazards like tobacco and drugs and alcohol. And so my work in particular, it actually does span across the entire lifespan, working with families who are wanting to continue breastfeeding, so providing a statewide breastfeeding recognition program, to working in schools to ensure that students have access to physical activity and nutrition, all the way through working with communities to ensure that they're walkable and folks have ways to access recreation, jobs, education, and then even working in the clinical setting, as a lot of our chronic disease prevention and management efforts do afford us an opportunity to work with our clinical partners, both at federally qualified health centers, as well as hospitals and healthcare systems too. And so again, continue to think about what public health is. There is with most sciences, there is a typical public health approach. So when we think about what all public health encompasses, thinking about the broader context, public health problems are diverse, and they do range: infectious disease, chronic diseases, emergencies, injury, environmental health, and so on. And so regardless of this topic, we focus on a similar process. And so the surveillance piece, which I'll touch on more, is like identifying a problem. So what's the problem and what data is related to that? How do we keep track of it? We're then able to look at what risk factors do attribute to it. So what are the cause to some of those problems that we're seeing? It then allows us to put in place some interventions, which we then are able to figure out if it's working successfully or not, and how do we tweak those interventions and those activities to ensure that they're more effective. And then, really refining it so that we can move directly into that implementation and long-term sustained efforts to ensure that we're providing the right tools and resources and education to the population to ensure that they have access to those things which do improve their health and health outcomes. And so again, this is just a list of some of those things that we're thinking about in terms of the broader public health context. And I'll focus again on the surveillance piece or the data piece. I consider myself a public health data geek, which I don't think is a bad thing, because I use data to inform our decisions and ultimately show our results. And so today I'll focus on just a few of the more commonly used data sets as it relates to the public health work that I do and many others do, either at the local level, state, or federal level. And so these are just a few of those that I'll touch on today. So the behavioral risk factor surveillance system. The BRFSS is a national system of health-related telephone surveys that collect state data about U.S. residents regarding their health-related risks. And these are behaviors, their chronic health conditions, and the use of preventative services, like if they're receiving counseling referral from a physician to eat healthy or to exercise. And then also thinking about how do we use that data to ensure that we're creating programs that are able to address these different issues. So as I mentioned, this is a telephonic survey. They've moved into, I guess, the 20th century in some instances, and trying to do a variety of different ways to connect with individuals. As we know, many people don't have home telephones anymore. We don't answer telemarketer calls. And so looking at ways that these data can be collected through mail-in or through electronic means too. And so while this is a nationally collected data, we do have epidemiologists at VDH who are able to analyze these data, and they present these wonderful gradated maps for us. And so this is an example of when we collect those data, what we're able to show in terms of burden for, in this example, arthritis. So I do oversee our arthritis program, in which we're looking at connecting individuals to opportunities for physical activity, as well as evidence-based interventions to improve their health outcomes. And so what the BRFIS does, and some others that you'll see in just a moment, they allow us to see where we're seeing the most people at risk or exhibiting those health outcomes, so that we can target programs. So as you can see here on the screen, this darker blue area is an area which would be of concern for us, as we're seeing many people with arthritis in that area. So we could then target interventions, education, connection with physical activity and other providers to help reduce that burden. And so the BRFIS does focus on adults. The Virginia Youth Survey is a survey that is focused on youth, as the title states. And so this survey has been developed to monitor priority risk behaviors that attribute to the leading cause of death and disability and social problems among youth. And so this is something that is done throughout the country, but in Virginia, we call ours the Virginia Youth Survey. And so it's administered every odd year, and it's administered randomly in selected Virginia public schools. And some of the topics that are collected are tobacco use, alcohol use, and other drug use, unhealthy dietary behaviors, inadequate levels of physical activity, and behaviors that contribute to unintentional injury and violence too. And so this is just a snapshot of what some of those data are. I mentioned that the Virginia Youth Survey is done on a biannual basis. The BRFIS is done on an annual basis. Another data component that we look at, or data set, is the concentrated disadvantage data set, which looks at or categorizes census tracts. So it's a smaller level, where some of ours are county level or even health district level. This one gets down to the census tract, and it allows us to look at the proportions of household per census tract with high level of concentrated disadvantage, which means that we're looking at certain risk factors that can cause individuals to have a higher rate for the development of specific conditions. And so it's looking at poverty level. It's looking at the number of individuals in a particular area that receive public assistance. It's looking at the number of female-headed households, so single-family households. It's looking at the percent of unemployed, and it's also looking at the number of individuals or residents in that particular census tract that are under the age of 18. And so one of the things that we've been able to do with these data is look at concentrated disadvantage, which is a reliable data source, and it has been used in maternal child health and some other programmatic areas, is to be able to look at those factors and then see, based on our diabetes burden, where we need to promote diabetes self-management education sites. And so as you can see, we know that the red pins show where programs are. And then we align that where we're seeing a lot of concentrated disadvantage or need. And so we can see that in some of our darker areas, again, in here in the far southwest, and even some on the eastern shore, and then south side areas of the state, we don't have programs. And that we're not looking at causation, but we do see that we don't have programs there, and so that may be contributing to the rise in the number of cases of diabetes. And so that could be areas that we would want to put more programs or do a special focus in ensuring that we have the adequate resources to those areas. And so now we have the capability of working with telehealth and telemedicine, and so we wouldn't have to physically have those types of resources there, but being able to figure out ways that we could still tap into our network and provide support where it's needed. We also look at another index called the Health Opportunity Index. And this is more geared towards some social epidemiological data. And so it's looking at a variety of different factors that, like the previous slide, it does look at those social, economic, environmental, and geographic factors. And so those factors include, for instance, the number of individuals who are below the federal poverty line. It looks at employment and income opportunities. It looks at access to physical or mental health. It looks at other social factors like spatial segregation. It looks at reduction in educational opportunities as well. And so with the HOI, or Health Opportunity Index, it gives us scores, if you will, across all of the different factors to determine, do individuals living in these particular areas have an opportunity to obtain optimal health? And so I think a common theme across many of these is we see the same areas regardless of concentrated disadvantage, arthritis burden, diabetes burden. We're seeing the same areas lit up across the state where we're seeing these opportunities for us to really target interventions and programs in those areas. And the Health Opportunity Index is just another indicator of that. And when we couple a lot of these things together, we know that place and zip code determine lifespan. And this graphic here is from the study at VCU Center on Society and Health. And we know that, there are systemic challenges, racism, barriers in place that do really drive home the factor that where you're born, where you live, determines how well you live and how long you live. And from this graphic here, we can see just a snapshot of Richmond, that there is a 20-year life expectancy gap just across the I-95 corridor, meaning that individuals living in Westover Hills have an opportunity to live 20 years longer than someone who may have grown up and lived in Gilpin Court. And so I think it's probably another day to have a conversation about systemic racism and issues that cause these redlining and a variety of different policies that have been put in place that do lead to some of these health outcomes. But just to point out, when we've heard our speakers previously talking about access to parks and green spaces, access to healthcare and education, all of those factors do determine our health. And using data to show where there are gaps and where there are opportunities allow us great opportunity, to overuse the word again, to be able to provide those infrastructure and systematic ways to be able to make improvements across a variety of different things. We also use clinical data. Clinical data does drive a lot of our decisions, and then it allows us to look more upstream in terms of where we want to put preventative measures in place. And so this can be looking at EHR data. This could be looking at the uniform data set, data that's collected from federally qualified health centers. There's a variety of different ways that we could track clinical data. A more recent example is looking at hospitalizations around COVID-19. And so seeing where there is, the number of beds, the number of ventilators, there are maps that are developed to show where the prevalence rates are for new cases and even deaths as it relates to it. So this is just another example of how we use data in the public health setting. Other data that are used that are not necessarily public health, but do help us make informed decisions about our programs and about our activities and strategies are looking at USDA data. We're looking at food insecurity and where we may want to partner with farmers markets or food banks, looking at economic data, transportation data in terms of injury, pedestrian crash data, sidewalk data. And then as we're also thinking about the overall environment, looking at temperature and heat index data. As a way to think more strategically about planning in terms of where you want to put green spaces and parks and trails. And so I want to share an example of how we've been able to coalesce a lot of these data to make our informed decisions that allow us to be able to work across multiple sectors, to be able to stand up programs, services, and partnerships to be able to tackle some of these very complex health-related conditions. And so just thinking about, the context of place and space, we know that there are policies and plans that have shifted kind of how our neighborhoods and how our communities look. And we know that over time that has changed due to a variety of different factors. And then taking all of that information to one, for us, we've developed several programs that allow us to work with our planners and transportation partners, our public works, as well as our public parks and recreation partners, to think about where do we need to promote access to green spaces, trails, and parks, and then also what are ways that we can engage communities in order to do that. And so that's one way, looking at the environmental changes that can be made. The other piece is looking at where we position our programs and how do we not only connect with partners, but we connect our partner network and make that web that we need in order to better serve Virginians, regardless of their zip code or their county. Another way that we do it, so we've looked at ways to improve access to parks through either signage or creating trails, all of those things. And then thinking on an individual basis about how do we connect individuals not only to the parks, but to programs. So for example, I've mentioned the arthritis program and the work that we do in terms of connecting individuals to evidence-based programs and physical activity, which can take place in a park or even their neighborhood. We're able to utilize the data to pinpoint where we need programs, but we're also able to collect data on outcomes. And we're also able to utilize those clinical data, so looking at an electronic medical record to identify patients and create patient registries to then refer through their physicians to these different opportunities. So an example of a pilot project that we're currently working on is through some supplemental funding that we've received from the National Association of Chronic Disease Directors to be able to create a referral system for federally qualified health centers to connect their patients to these opportunities for education and physical activity. And so developing this referral system that allows physicians to do just that. So working with our staff through our Red Cap referral system to refer patients to our Walk with Ease program, which has been pre-COVID a group-based leader-led intervention in which we have participants connect with one another to build self-efficacy and also endurance through the assistance of a trained leader to improve their walking in their neighborhoods or their parks. And then we've moved more into self-guided so that we're adhering to social distance guidelines, but nonetheless being able to connect individuals to those types of evidence-based interventions or chronic disease self-management program or diabetes self-management program, and then also encouraging that they do, in addition to receiving that education, get out and walk in their neighborhood or bike if they so choose. And so this allows for us to work with our clinical partners and connect them to those community-based linkages to improve health and well-being overall. And so even with all the data sort of on the background driving your decisions, it's also important to think about impact and how do you measure that success. And so whether it's process measures in terms of counting the number of people that visit parks or fulfill a park prescription or that get referred to an individual program, also thinking about what the health impact is. So is there a reduction in A1C numbers if they're diabetic? Is there improved self-efficacy? Is there a reduction in joint pain? Is there an improved or reduction in weight, or have they lost weight due to their participation in the program or physical activity. And then also thinking broader about not just the individual aspects, but in terms of driving individuals to parks or increasing access or improving signage and improving access to these green spaces and these wonderful natural resources that we have. Is it having an economic impact? Are you increasing visitorship? You know, I think there are a variety of different ways that you can sort of pin what success looks like by utilizing your data in the appropriate way. And then lastly, I just wanted to touch on the data portal that VDH has developed. And so this data portal can be found on the VDH website. And here you can access a variety of different data. So those that I've talked about before. But if you're needing assistance, we also have here on the screen, you can see an email to connect with our population health epidemiologists and evaluators to be able to get you data. There's also the availability to download data either in PowerPoint form, PDF form, and then even in some cases you can get raw data if you want to do analyses. But our team, both myself on the programmatic side and our evaluation and epidemiology folks, are always willing and able to assist you to identify those data, whether you're just wanting to have data to make data-driven decisions, or if you're writing a grant and need some health-related data, we're always here to be willing to assist you in your efforts. And with that, it does conclude my presentation. I think now maybe we have a time for some questions.
Yes, we do. So thank you very much, Millicent. And again, some of those statistics that you shared are absolutely astounding. There's a number of questions, and my colleague Debbie Spiliotopoulos, who is an environmental planner at NVRC, is going to facilitate us through the question and answer discussion session. Debbie is also the program manager for the bicycle and pedestrian work that we do at NVRC. So Debbie, do I need to share anything with you?
No, I think I'm good. Hi, everybody. Thank you so much for participating in this this call. I'll show myself. I guess if the panelists want to, if you all want to show your screens, we can all, you all can at least see us. And Corey, thanks so much, and Millicent and Sheila and Ann, thank you for amazing presentations. As Corey said, I'm another senior environmental planner, and we work together on trails, and I also work in bicycle and pedestrian safety, and also on waste management, which is unrelated to what we're doing right now. I just wanted to go through the questions. So I'm going to actually turn off my screen for a second because I'll be looking like I'm reading and my eyes will be somewhere else. So we had a number of questions. I mean, I think everybody was kind of overwhelmed by Sheila, everybody's comments. But there was Bethany from Department of Health mentioned that there's research that supports has supported that obese generation of children will not outlive their parents because of health complications, which is just absolutely heartbreaking. And then I didn't know if, and I'll do any of you, and then somebody else wrote, you know, these are really staggering statistics. We're going off a cliff. Can you all maybe give a little more comment on like what you see in terms of what we can do in our different roles as local governments or nonprofits or state people, you know, what you really see it. You're all working on these issues. Do you have some recommendations just to respond to that? Millicent, you want to go first?
Recommendations. I can speak to some of the work that we're doing as it relates to especially the physical activity piece as it relates to youth. And there may be an opportunity for partnership as I'm thinking through this, and feel free to reach out. I think maybe one of my coordinators is on the call too, so we can connect. But as it relates to the work that we're doing in the school system, I alluded to just very briefly, is identifying ways and identifying those champions, so those health and PE teachers, and we call them our Chief Movement Officer cadre. And so these individuals are highly enthusiastic, trained individuals that actually work with classroom teachers to connect education and physical activity. We know that it's changed now due to COVID and students learning remotely, but there are opportunities perhaps to connect parks and those CMO cadre members to encourage students to go out into these natural spaces to be able to engage in physical activity, and tying it to history walks or monuments or those sorts of learning opportunities, so that yet they are able to continue that education component, but also do something fun and physical to be able to connect those synapses even greater.
Just a quick follow-up. Do you work with Safe Routes to Schools coordinators as well?
On tangentially, yes. We also, I didn't mention our Virginia Walkability Action Institute, but we have some of them that participate as part of our local teams. So we have done some work in terms of improving safe routes to school.
That's great, because those are some of our folks up here who on pedestrian safety and encouraging pedestrian activities and biking have been amazing. Sheila, do you want to add anything? Oh, can't hear ya. Unmute. You can turn off your screen if you think that's a problem for you. Oh, you froze. And Anne, you're muted too, I think. I still can't hear you, Anne. I'll turn off my screen. Maybe that will help. Does that help? Can you all hear?
Oh, I'm right here. Can you hear me okay, Debbie?
Yeah.
Yeah, I would just say, I know from my involvement working with Dr. Robert Czar when I was supporting what was DC Park Prescriptions, which became later ParkRx America, I know anecdotally that he had great success where, a lot of what Sheila had shared is, the health provider can be that connector for especially non-traditional communities and audiences with our parks. And it's really about finding out how to make time within your day. And it's not really about necessarily exercising, but movement. And so by finding out really what the schedule was for this young person, he was able to suggest that the person got off the bus 6 stops early to actually walk through, an urban park trail, where it was safe to get to school. And over time, that child became less obese and then was in a non-obese category. Now, that was not scientifically proven, in terms of what you heard from the presentations on the health perspective, but there's that. And I do think also in terms of for the National Park Service, I did want to call out two other great resources that the National Park Service created with the CDC. There's the Park Trails Health Workbook, which speaks to some of the things that you heard in terms of other resources, and also the 8 Common Measures of Health. I think that Safe Routes to Schools has great resources, how students and also seniors in the community can work to create walkability audits to look at safe places. Because when we look at trails, oftentimes people are looking at doing small loops. So I think when for me, with the Potomac Heritage National Scenic Trail, thinking about different loops for those adjacent communities to have that access.
Great. Oh, that reminds me, I forgot to tell everyone what NVRC has been doing. We have, and then I have a bunch of other questions for you all. So NVRC has been, we have been partnering, of course, with the National Park Service. And right now we're working on a number of different activities. One is we're completing a public access to water, for the rivers and streams for that kind of recreation. We're also mapping access to parks and overlaying with demographics and crash data, which I think what has already been happening with VDOT and Millicent and the folks in Department of Health, we're hoping to do that, kind of focusing in on the Heritage Trail and how we can use that to kind of determine where we go with trail gaps and other elements. And we are also going to be doing, we're funded to do a study of the economic health benefits of the trail. So actually getting some analysis for Northern Virginia on that. So with that in mind, I'll have a question for that at the end, but I want to get through the comments and questions that folks had. One was, do you all think that guidelines, or do guidelines exist now where you can tie development and transportation projects to access to parks and connections for communities to have greater or more amenities in a park, or requiring a park for X number of people? Any info, any response to that?
So is the question, is there guidance or should there be guidance? I think I may have misheard the first part.
I think it's both. If
Okay.
there is, or should there be, or especially from the local level, maybe?
Yeah, I would say definitely. And I think as we're thinking about what that guidance is, it needs to be more encompassing than just thinking about environmental and economic impact, also including the health impact and what some of those factors could be. Also thinking about health equity and racial equity, and then thinking about different levels of ability also. So accessibility in terms of limited mobility. So there, you could think about older adults who may use motorized or assistive devices, and thinking about what access looks like for those individuals. But then also thinking about, placing some of those access points to some of the areas that have been most disadvantaged, or who may have been gentrified or are on the verge of being gentrified. So it not only improves health impacts, but also economic benefits by increasing access to those areas too.
Great, thank you. And then just to follow up on that, that's something I wonder about, is when you actually provide does it, making sure that once you provide the amenities for the community doesn't get pushed out, because
Right.
now, with the gentrification.
Yeah, and one way to do that is to include the communities in which you're going to make those developments, engaging them in the entire process, not just after you've made your plans. They should be a part of it from the start. I think there's some groups use the nothing about us without us. So including them from the early planning stages, ensuring that there's equitable access to your planning meetings, having transportation, having childcare, having food, having them at times in which is amenable to working families and single families too.
That's great. Thanks.
Yeah, I think just to add, Debbie, I think it's about meeting also the communities where they are, because often with the public process, that it's in the evening and it's not always a diverse representation of a city or county that is able to come. And so looking at other methods to get that input. I know from another another presentation last week where there was I think in a community which was getting public input where a low-income community was getting their food during COVID in terms of free resources to get some input from communities that way.
That's a really great point, and that's something. Just so the folks on the line know, VDH had a really great webinar last week on STEM, and one of the things they talked about was that you all went into that in some detail, and I was thinking, I wonder if there's something we could do at NVRC just to offer a webinar, because the day after that I was on a webinar for waste management, and people were bringing up the same issue, that with COVID especially, you've lost the ability to really do effective public meetings. So I think maybe if we do some kind of training on some options or techniques or case studies, in this kind of a format, I think there'd be a really broad range of people who would be interested to start thinking about that.
Yeah, absolutely. We'd love to.
Yeah, great. So there was another great question Ernest Rodriguez brought up. Are nonprofits able to provide input for park amenities? Do you have, Anne, do you want to answer that? Or if anybody has on the chat would like to bring up your perspective on that as well. I know we have a lot of parks folks partnering with nonprofits. Anyone? Or do either of you, Anne, do you have a response to that?
I think that partnerships are extremely important. I think that, there are different situations in terms of federal lands. I think as it relates to the Potomac Heritage National Scenic Trail, the beauty of it is that the majority of the lands are non-federal, so they're local, regional, state, or other federal lands. And so depending on the regulations for that land agency, yes, there could be a nonprofit that might be managing an aspect of a park. I know within the District of Columbia, there's a nonprofit that runs a rec center for the DC government in terms of providing that opportunity for the community. So I think there are situations like that, and definitely, in terms of national parks, there are national parks which have different cooperative agreements in terms of helping, in terms of working together, in terms of management. So it depends on a park entity, but I would open it, Debbie, if there's anyone else who wants to comment on that.
Okay, I'm looking in the listserv. Oh no, Sheila was having a lot of trouble with her connections. But she brought up ParkRx is a nonprofit, and we would be happy to provide input into amenities planning for local parks, since our local prescribers are in tune with what patients need and are interested in doing outdoors, which is awesome. Thank you, Sheila. I think that might be another thing where we could have maybe a webinar just on that, or provide some resources for folks if people are interested. And then Megan, Sheila, I'm shooting this out to you, that Megan from Virginia Department of Health would like to reach out with you after today. We will share with everyone, in addition to the video, we'll try to take the links off of your presentations and also your contact information, because I'm sure a number of people on the call, on the webinar, would be interested in maybe following up. And then the last thing is, do you actually, I guess, Anne, you had mentioned that, let's see, you had mentioned that you can get health companies to cover the cost of entrance fees. Do you want to go into a little bit about that?
Sure. So in the past, with my work with supporting DC Park Prescriptions, with the DC Park Prescriptions Coalition, Dr. Czar and I sat on what was the National Park Prescription Steering Committee, which had been facilitated by the Institute at the Golden Gate. And so there are examples in other areas of the country. I had a colleague out in Oregon where they did a pilot working with a local health clinic, and the local health clinic paid for the National Park, the America the Beautiful Pass for the National Park Service, for the patients to be able to go to the park without having to pay an entrance fee. So just as, you know, just as a citizen, I know that with Blue Cross Blue Shield, if you're taking care of yourself in terms of your health, Blue Cross Blue Shield will give you back $50. So I think it's a conversation for us to have regionally here. Many of our national parks are free, and there is the America the Beautiful Pass for federal lands, but I think when we think regionally, there's no such type of pass for any of the lands that have a fee where it could be cost prohibitive. So that might be something interesting for a future conversation with folks who have fees to try to figure that out.
And that's actually that would actually be an interesting overlay as well when you're looking at opportunities, is what are the barriers to even using the parks, if there is like an entrance fee or something like that.
Yeah, I know, Debbie, I know that Dr. Rajani, who practices out in the San Francisco area, she had done a study where she found that just having providers refer patients to parks in terms of getting the information about access, where they could go to do an activity that they enjoy doing, was really successful. It was actually more successful in that study than linking the patient to the park than with programming, although we know from Melissa that programming is really important, especially for populations that may not know how to enjoy or do a certain type of outdoor recreation in a park if they haven't been given the leisure time. So I think that's an important thing to think about for us here.
That's an interesting point about the leisure time, you know, about having kind of control of your life enough to have the time to do what you need. I think there was one more comment from Tammy Fahrenholt. Hopefully I said your name correctly. I apologize if I didn't. There are also nonprofits that manage green spaces and parks. So they would love to partner and assist in addressing gaps. So that's great to hear as well. So I guess circling back, I would love to hear from both of you, and I'll keep my eyes peeled for Sheila's comments in the chat since I'm going to be her voice mouthpiece for a little bit. What do you all think in terms of with what we're doing or what park and trail folks can do, and you know what NVRC has planned? What would you like to see us move into? What would be helpful to move forward, both through our projects and to build on what you all are doing?
So I can start. There are two immediate opportunities that I could see us partnering with. Both of which I should say I've alluded to in the presentation. So the first one is thinking about connection between clinical partners and community partners, or parks and rec or trails. And so we have an opportunity to pilot another referral system, if you will, with our clinical partners. And so if there's a park that's interested in getting those prescriptions for physical activity, or if there are clinicians that are interested in doing that. And so whether that's, you know, ParkRx or building a low-tech homegrown system, we're able to provide some funding in order to assist you with doing that. And then on the other level, thinking about how do we train practitioners to be able to work more collaboratively. And we do that through our Virginia Walkability Action Institute, in which we actually bring together multi-sectoral partners to address accessibility issues, looking through health equity and transportation justice lens to increase access to these public spaces through walking as a primary mode of transportation. And so we will be opening up our next cohort for our 2020-2021 teams. And so we'd love to talk more with you about how to be a new member or a new team for us, or if you're interested in just talking about multi-sectoral partnership and things that we can do together, always happy to have a conversation.
It's great. And Anne, what are your thoughts?
Yeah, thank you. Well, I think one thing for you all to realize is that for Northern Virginia, before ParkRx America was established as a nonprofit, I had some interns and we worked with some college students at George Mason University, where we actually helped gather park data, and we worked with many of your park agencies. And so I would encourage you, ParkRx America is a promising practice, but nowhere in the country do we have the regional mapping as we do at the moment for Northern Virginia, for Washington, D.C., for Montgomery County, and the counties adjacent to D.C., I think Prince George's County as well. And so I think there's an opportunity there in terms of the mapping, and really maybe it's what Melissa was saying in terms of connecting with clinicians. I have had success, within the National Park Service, we have a teacher ranger teacher program where teachers will sometimes spend the summer in parks. And like that model, I've worked with a professor at George Washington University, where I've worked with physical therapy students who have actually thought about parks in terms of a health setting with what you've heard, to help us as parks translate the health language to internally for for park managers, but also to create messages for us to better connect with our community, with visitors, to realize that that our parks have other benefits, and we are part of that one health in terms of, and when there is not access to our parks and trails, realizing that we are a part of the problem. And so I think that could be an interesting kind of conversation going from here, Debbie, as it relates with the Potomac Heritage National Scenic Trail.
Great. Well, thank you. I have a comment from Sheila as well. She had input. She said, identifying green space in every neighborhood and increasing the number of parks in our ParkRx database. So I hope that these, we have people from all over the state and in Maryland as well on this. So I hope that everyone has learned something. I really appreciate everyone's time, and I know Corey does as well. Corey, do you want to sign off? We're 2 minutes, I think a minute over. So I just wanted to thank everyone again for this. And Corey, if I don't hear from you, I'm going to close it. And again, we are going to have this copy. We've made a recording of it, and we will move on from there to provide some outreach of this afterwards. Thank you.
Thank you.
Thank you, everyone.
You don't have to, Debbie, you can go ahead and close it.
Okay, and thank you, Sheila and Melissa and Anne, for fantastic presentations. Thank you again.
Thank you for having us.
Thank you.
Okay,
Bye.
thanks. Bye-bye.
Thank you. Bye-bye.